other local officials, Dr. Frieden and others, head of UT Knoxville's Medical Center, Dr. Lacey, are here. And here's what we propose to do. We'd like to have a loosely structured discussion for about 45 minutes to 50. And I'll open it, and then Dr. Frieden will say something. And then we'll ask each of our roundtable participants to take about 3 minutes from their perspective on this issue. And when we get toward the end, I'd like to reserve 5 or 10 minutes to see if there are any comments or questions from the experts who are out there. I know Representative Bill Dunn said he might have a question or a comment to make, and it'd be good to hear from any of you. Our goal is to take advantage of this visit by Tom Frieden on this important issue and see what we can do at the state level and in my job as the chairman of the United States Senate's Health Committee to make it easier to deal with this new epidemic. So let me do the introduction, then turn it over to Dr. Frieden. First, let me introduce Dr. Frieden to Knoxville. He is the head of the Centers for Disease Control. That is a federal agency in Atlanta, headquartered in Atlanta. People always say, why don't you move some of this stuff out of Washington? Well, we have, and that's in Atlanta. And although he spends most of the federal dollars he spends through state and local health care agencies. For example, our state and local public health care agencies did a magnificent job in detecting the source of the compounding pharmacy infections that we had that was killing people a couple of 3 years ago. And it was that partnership that made such a difference. He's always looking for diseases or epidemics or problems around the world that might come here. For example, Ebola. We spent a lot of time and money, led by CDC, to try to get rid of Ebola in Africa so it wouldn't infect people here. And he has, so he's always dealing with the newest epidemic that's likely to kill the largest numbers of us. And his goal is to is to save the most lives that he can, which is something that interests every one of us. He's one of our leading healthcare officials and great public servant. It's terrific to have Dr. Frieden in Knoxville. Now, let me introduce Knoxville to Dr. Frieden in a way I tried to suggest yesterday to an audience in Oak Ridge that actually I've been trying for about 30 years with no effect, which shows you how much of influence I've got around here. But I think the time has come for Knoxville to think of itself this way. And I would say, Dr. Frieden, welcome to Knoxville, Tennessee, which is bordered by the Great Smoky Mountain National Park, the most visited national park in our country, and the Oak Ridge Corridor, which is one of the country's largest concentrations of brain power in scientific research, in advanced technology, and supercomputing. That part of Knoxville's personality doesn't always get as much attention as I think it should. We looked it up. There are about 40,000 professionals in Anderson, Knox, and Roane counties who have graduate or professional degrees. And that includes 1,600 scientists and engineers at the Oak Ridge National Laboratory. It includes more than 1,000 PhDs at the University of Tennessee, hundreds of engineers at the Tennessee Valley Authority and the Y-12 nuclear complex. So it's one of the most formidable concentrations of scientific brain power anywhere in the country. And just as the Research Triangle has come to signify that concentration in North Carolina, and Route 128 has come to signify that in Massachusetts, and the Silicon Valley in California, I see no reason why the Oak Ridge Corridor shouldn't become that kind of brand name. It's instantly recognized anywhere in the world. If you're the mayor of Knox County and you walk into any office anywhere in the world and say, I'm from the Oak Ridge Corridor, you're likely to get your second sentence paid attention to. If you walk in and say, I'm the mayor of Marable, they might not listen because they don't immediately associate that with the amount of scientific brain power that exists here. But just last week, I was at DENSO's announcement where which is one of the most advanced manufacturing companies in the world, and they're at the other end of what I would call the Oak Ridge corridor in Blount County. So while I had so many influential people captured here today, I wanted to remake that suggestion that I think it's time to emphasize that part of Knoxville's personality. Now, Dr. Frieden and I had a chance to have our conversations in the other room. Most of you heard that. We're talking about one of the newest healthcare epidemics, prescription drug overuse, painkiller abuse. It affects 1 in 20 Tennesseans. We're at the top of the list, toward the top of the list for prescription drug overuse, third, 12th in the country for the number of people who died because of it. 1,000 people died because of it last year. We think we can do something about it. And actually the state, Governor Haslam's leadership, and your leadership is beginning to do that. So Dr. Frieden, why don't you comment, and then let's take about 3 minutes each from everyone here who will introduce themselves, and then we'll have a little conversation and leave time for you to make comments or ask questions. Dr. Frieden, welcome to Knoxville.
Thank you very much, Senator. It's great to be here. Actually, my first job right out of college was working for Vanderbilt in Tennessee. So it's great to be back and wonderful to be here. And I want to thank Senator Alexandar for his leadership in so many important issues that face us as a country, face us here in Tennessee, and face communities and families, including prescription opiate overdose. Tragically, prescription opiate overdose is increasing in the U.S. It has been for the last 15 years. It has gotten worse than I think any of us could have predicted. In the past decade alone, 145,000 Americans have lost their lives to prescription opiate overdose, most of them young people, and most of them quite preventable. I'll repeat a couple of things I said in the other room, so apologies for those of you who heard them there, but for those of you who didn't, I think the facts about prescription opiates are really important to get clear. For some people, they're essential. If you've got terminal cancer and you're in excruciating pain, these are godsend. But for most people with pain, the risks are going to far outweigh the benefits. The risks are two. One, they're highly addictive. Take a few pills and you can be struggling with addiction for life. And two, they're lethal. Take a few too many and your breathing stops and you can die. So we have to get the balance right with how we use them. And it's not only overdose. We're seeing outbreaks of hepatitis C and HIV for the first time in a generation in this country. I'm an infectious disease physician by training. I did my training in the 1980s when we saw lots of injection drug use. And for a generation, we didn't see it. Last year, in one small town in southern Indiana, we saw 180 new HIV infections. 180 people are going to be struggling with that for life, and many more hepatitis C infections. And the cost, just for that one community, is going to be in the range of $100 million for something that came in 1 year, less than 12 months. And that's what we're at risk for, and that's what we're trying to confront with today's events and the work that the state is doing here and the work that the community is doing. It really is a crisis, and we need national, state, local, community-wide, family, and individual action to deal with it. We need the whole healthcare system involved in addressing it. At CDC, what we try to do is first get the data, show what's really happening, shine a light on it, real-time information for effective action. Second, empower doctors and nurses and pharmacists and other healthcare workers so that they can make sure that patients are getting the safest treatment available. And third, do what works to reverse the problem. Community coalitions, opiate reversals, improved prescribing patterns, prescription drug monitoring programs, and things that will make a difference today. We also want to make sure that we're recognizing the progress at the state and local level. And the reason that we're providing Tennessee additional funds, we had 34 states that all needed the resources, that all provided good proposals, but we only had funds for 16 of them. So we funded 16 states. We're announcing today. Tennessee is one of them. Last year we could only fund 5. So Tennessee was one of them also because of the good quality of the work being done here. And we hope next year we'll be able to fund all 50 states because it's a national problem. For the first time in many years, we've seen some progress here in Tennessee and around the country. So there is progress, but there are real challenges as well. We're nowhere near out of the woods. We have a lot farther to go. The funding for Tennessee will be $861,000 a year for 4 years, or a little over $3.4 million to run programs here. And we're hopeful that Tennessee can show the way in dramatically improving the way pain is treated so that fewer people get addicted in the first place, and the way we provide services to people who are addicted so fewer people die and fewer mothers give birth to children who have to struggle with neonatal abstinence syndrome. Our brains evolved so that we would be able in an emergency to have a chemical released and allow us to survive even if we were in great pain. There are opiates that are produced by our own brains in extreme situations. But now what happens is we have drugs, whether it's heroin or prescription opiates, that trigger that same reaction in the brain and are highly addictive. And we need to understand just how dangerous those drugs are so we can prevent more overdoses and deaths and more tragedies in communities. I want to thank Senator Alexandar for bringing us here together. And when I think about solutions, I often think about what we call at CDC a technical package. So rather than doing a little bit of everything and hope it works, find the 4 or 5 things that are likely to make the biggest difference, and then get those implemented everywhere in a way that supports families and communities, does what works, tracks it, so we're always improving our program based on what the facts show and what the science shows. That includes real-time prescription monitoring programs. That includes involving all of the payers, whether it's Medicare, Medicaid, worker compensation, health systems. That improves improving treatment of opiate overdose and opiate addiction, reducing the availability of heroin, so law enforcement has a very important role to play here. We know that when an addictive substance becomes more expensive or less available, it's less used. So law enforcement is a key part of the puzzle here, resolving it. And rigorous real-time monitoring so we can take action. One of the things that the funds will allow is rapid response teams to be able to respond if there's a flurry of problems in one area, to immediately go in with services and also appropriate law enforcement or licensure issues if there are physicians who are using their license to sell drugs, which is a very rare phenomenon, but it should be a zero phenomenon. I want to just end by thanking you for what you do, and I'm looking forward to listening and learning in the time we have together. So thank you very much.
Thanks, Dr. Frieden. Now let's have a reaction from our panelists to what Dr. Frieden has said. Let me ask you to try to keep your thoughts to about 3 minutes, which will allow us to have more time for conversation and other comments. Dr. Randal Dabbs is an emergency room physician, so he knows a lot on the front lines about the pain and the proper prescription for that. And I think the first question, Dr. Dabbs, I think most of us is, a lot of this starts with prescriptions from physicians. So what's appropriate? What do we do about that? What's been your experience?
Well, my experience, I feel like I'm a specialist in the problems that we're talking about, because I'm a specialist in pain management, and certainly addiction and overdose, because we see all of that in the ED. And as a physician who's worked in the ED for 38 years, I was director of the emergency department at the University of Hospital for 20 of those years, and founded a company called Team Health. We employ over 15,000 physicians and see 15 million patients across the United States. So we're pretty familiar with the problems, that prescription drugs cost across the country. And as Dr. Frieden said, this is not a new problem. I chaired a task force as president of the Academy of Medicine back in 1998, was the first one. So it's not something that just happened. We had the same issues of, overprescribing or theft of prescription pads, and tried to work to deal with that. But due to a lack of funding and resources, that kind of went away in about 2000. And then in the last couple of years have served on a commission that the Metropolitan Drug Commission and the Academy has set forth, and it's another prescription drug task force. A lot of people in this room, Randy Nichols and Chief Roush and other people sat on that committee, and I think, again, hopefully some of the benefits that you're talking about, Dr. Frieden, in terms of reduction in the number of morphine equivalents that's being prescribed and used in Tennessee has decreased. So again, it's not a new problem. The way I see it is that by the time that we see patients in the ED, so many of these of our ability to react is kind of lost. I mean, we are under a crunch of unfortunately, I don't have 20 minutes, as you know, to sit and educate a patient about the ills and about appropriate pain medication, and why we should use something other than a hydrocodone or a Percocet or something like that in appropriate use. So we need to start at just as early as possible to educate people so they don't assume that I'm going to go to the ED and I'm going to get 20 some sort of narcotic medications, and if I don't, then I have been mistreated. Because again, some years ago, the Center for Medicaid and Medicare Services made that statement. We all know that as a fifth vital sign, we feel pressure in the ED. We feel pressure as hospitalists. We feel pressure because the statement is that we need to treat a patient's pain, we feel like, to the maximum effort. And the question that comes out on our patient satisfaction surveys is, did your physician do everything possible to address your pain? That's how we interpret the wording. And so there are pressure on our physicians and our PAs, nurse practitioners, that if I don't give this patient what they want and enough pain medication, because they're not there for Tylenol, they're not there for aspirin, they're not there, they're there for heavy stuff. And it may be appropriately so that they just want their pain relieved, and sometimes we can't tell. We don't have a painometer. We can't stick it in the spinal cord and say, well, what degree of your pain do you really need? We like that research, though. So are you really in pain? What's your brain perception, and what's the best way to do that? We don't have the ability to do that. So certainly trying to work out a way to we address the sense that it's a right of mine, and it's true. We do need to treat pain appropriately. That's not the issue, but the better way to treat that. And so that the education and pressure are two. And the third is what you guys have already set up with a controlled substance database in Tennessee and other states, and that is the easiest way to get data on what's happened to this patient before they come to this ED. And it's as good as the database is, it is equally as difficult for our physicians who are under huge pressure for patient flow in the ED. You can't, it sometimes will take minutes and minutes to get that patient's information to see if they were seen at the hospital across the street or seen before. We just don't have 20 minutes to access. So whatever help we can get to improve the access to a patient's previous medical records, so we have an idea if this patient is a new patient, and then base my medication, my treatment upon their prior history, I think would be very well received by all of us.
Thanks, Dr. Dabbs. That's very helpful. On the electronic medical records, Dr. Frieden may later want to talk about. He was a pioneer in that in New York City when he was there. And in our Senate Health Committee, we're spending a lot of time on that right now, because the electronic medical health record system has gotten to meaningful use 2, and now 3 is coming down the road, and it's terrorizing some doctors, some hospitals. So we want it, but we want to do it in a way where physicians look forward to it rather than dread it in hospitals in the same way. So that's important. Dr. Reagan, you've already said some things in the other room, but What's your comment on what you've heard from Dr. Frieden and Dr. Dabbs?
Thank you, Senator Alexander. It is. I'll try not to repeat, but there's been a lot of good information here already. This is a process that's happened over many years, and we all have to, I think, as a community, own up to the fact that it's happening in our communities. And Knoxville is doing that, and I would really highly compliment you about that.
Can you bring your mic up?
I was just going to check and see, make sure it's.
Make sure it's on. That should help. Oh, is that any better? Oh, that sounds better. Okay.
You get closer to it, it'll help.
So I think, you know, I would like to emphasize something that Dr. Frieden said earlier. That this opioid dependence and addiction can happen to anyone. It's not some few people. There's a genetic predisposition that may make that a little easier for some than others. But all of us have those receptors. And if we hit those receptors often enough, all of us have a chance of becoming dependent. And I doubt there are too many of us in this room today that have not known a family member or a friend that's been impacted by this. This is extraordinarily common. However, the conversation about it is not nearly as common as the malady is. And I think that's something that we need to change across the state. This is happening to people. This is affecting their lives, and it is killing, in 2014, 1,263 Tennesseans. That's remarkable. This can be avoided. The dependence and the addiction can be avoided if the early signs are detected. It's easier to impact this early on than later on. I think that you heard that from Dr. Dabbs here. Even if dependence and addiction occur, they are treatable. It's a model of a chronic relapsing disease for most people, but it is treatable. And so connecting people as early as possible into treatment is, in my view, a very key thing to do. Naloxone is great, but naloxone gives us the opportunity to keep that person alive to go, to be able to participate in that treatment and to get their life back. I think working together in community-based organizations is critical. And that's where the funding from the CDC is announcing today is going to allow Tennessee to do more of that. And we're very pleased. The Department of Mental Health and Substance Abuse Services has already been working with coalitions across the state. And now the Department of Health is going to be able to be a more present and helpful partner in that. I think also there are some gaps in the knowledge and practical use of physicians and nurse practitioners and PAs around prescribing. We were told for years and years that opioids had a very low probability of causing dependence and addiction, less than 1%. We were told that over and over again. And as Dr. Frieden has said very clearly on a couple of occasions this morning, that is not true. That is not true. And so what it means is, as healthcare clinicians, prescribers, we have got to look at our own practices. The medical community needs to look in the mirror at our own practices on this one and understand that opioids are not the answer to all chronic pain problems. In fact, we now know that there's a syndrome where opioids can lead to more pain, not less. Who would have thought that? But that's the truth, the opioid hyperalgesic syndrome. So we need to be looking at the information, the real data. The epidemiology is there, the medical studies are there. There's not a lot long-term, and that's a real problem. Most of the long-term studies do not show efficacy for opioid analgesics for most conditions. And I think the medical community needs to come around that and needs to respond to that vigorously. Additionally, I think we have got to work together in terms of getting the message out to the public. And I'm glad today we're doing this. This is part of that process. But law enforcement is part of that. The healthcare community is part of that. The faith community is part of that. Our healthcare delivery system is part of that. The expert asking people for the early signs of substance abuse is really critical. The earlier you catch this, the easier it is to deal with and to correct. So I think all of these things working together. Just one last comment. I've had a chance to make some before, so I'll yield a little of my time. But we are actually looking at a a form of the controlled substance monitoring database data that would be available in emergency departments where the time frames are really tight, where we have pre-populated the reports for the patients, so that it's not having to go out and create a database, which is actually on average, the actual query takes about 10 seconds, but you've got to log on. There's a sequence of things that you have to do. So we're trying to look to see how can we make this information as readily available and as easy to use as possible, so that busy clinicians who are trying to do the right thing have the very best information available to them essentially instantaneously. Thank you.
Thanks, Dr. Reagan. And Dr. Buchanan, you're on the front line. You've heard that Tennessee has sort of the top of the list in terms of abuse of painkillers, and that in this region we have particular problems. What's your comment?
Well, again, I don't want to repeat what everybody else has said, and I agree that it's going to take a multi-pronged approach, and we didn't get here overnight, and we will not get out of here overnight. The Knox County Health Department is committed to working with the Tennessee Department of Health and the CDC and our Metropolitan Drug Commission, which is very active and very effective in coming up with evidence-based ways to make a difference. One of those is making naloxone more available in our city police force here in Knoxville. Will be carrying naloxone kits, so preventing those deaths and getting people opportunity to get into treatment for their addiction or abuse. And also, we're partnering with Kroger to possibly make that more available in our community. We know the evidence is out there. If you make the naloxone more available, you will save lives, and that will make a big difference. Knox County had 133 of the 1,200 deaths last year. That is disproportionate to our population across the state. We've got to do something to make a difference, and we're committed to doing that. But it's going to take a group approach, a community approach, and I think that's what's important about this meetings like this with Dr. Frieden here, and it really, the action happens on the ground here in Knox County, and you all are part of that, so I'm excited to be part of this.